Hello, my dear doctor. You'll be glad to know that the case that we are discussing here is ankylosing spondylitis, my dear. Ankylosing spondylitis is one of the most important cases that will be encountered, usually in station 5. My dear, in the station 5, it's just a brief clinical consultation, my dear. And under the headings of rheumatology, that you have seen that the station 5 brief clinical consultation. And under the headings of the rheumatology. Usually the scenario is posed like the shortness of breath on exhaustion. This gentleman presented with the shortness of breath on exhaustion, and now you have to take the history, clinical examination, managing the patient concerns. This is the station 5, my dear. And these ankylosing spondylitis can be presented in a varieties of stations, my dear, including, you see, there's a station 1, abdomen, but this is a little bit rare. And you'll have the good discussion in the spleen, abdomen, and you'll see the videos as well. So here is a hepatomegaly due to amyloidosis secondary to ankylosing spondylitis. Means the ankylosing spondylitis complicated by amyloidosis is a secondary amyloidosis because of the connective tissue disorders, and that leads to the hepatomegaly. So these are under the headings of the spleen, abdomen that are already discussed in the station 1 abdomen. So once again, the station 1 respiratory also, that you will get the case of the ankylosing spondylitis in station 1 respiratory. Similarly, the shortness of breath on exhaustion, or maybe the respiratory station. Then you enter the room, you have seen the spot, the diagnosis in ankylosing spondylitis, the features might and made the diagnosis of pulmonary fibrosis. So pulmonary fibrosis due to ankylosing spondylitis. And once again, the ankylosing spondylitis can be present in station 3 cardiology, my dear. So cardiology is single valvular disease, severe aortic regurgitation due to ankylosing spondylitis. So a core of features and the complications of the ankylosing spondylitis, my dear, already you know about it. Now what I'm going to do, my dear, this is very much important. The station 5, brief clinical consultation. Yes, my dear. So you'll have the very good discussions, my dear, in BCC, how the ankylosing spondylitis can be presented or can be in your exam, my dear. You'll have the lectures on and also some of the important tips and tricks and how to examine the ankylosing spondylitis fully, my dear, including definitely the ankylosing spondylitis, the skeletal features, the musculoskeletal examinations, and after that you will have the abdominal examinations, means in station 1 under the headings of station 1, and also in station 1 respiratory as well, the examination of the respiratory system to get the diagnosis of the pulmonary fibrosis, and also in cardiology to get the diagnosis of aortic regurgitations, my dear. In a variety of ways that you'll get the ankylosing spondylitis, my dear. So what I'm going to do, you'll see, my dear, the station 5 brief clinical consultation, the rheumatology, basically the skeletal features and musculoskeletal examinations, and followed by definitely you'll have the abdomen under the headings of hepatomegaly, and then the respiratory, and then definitely the cardiology. A very good discussion that you will have, my dear, face by face. And I hope and believe that, my dear, after having this case of ankylosing spondylitis, if you have the case in your exam, my dear, you will do the best, my dear. Best of luck. Enjoy the case, my dear. And definitely make some notes on the SS boxes that the boxes are provided to you. You will do the best, my dear. Thank you. Thank you very much.
So yes, my dear doctor, listen very carefully. The station 5, you'll get the scenario outside the room. And this man here is written that Mr. X, the 50 years old, has increasing difficulties mobilizing and performing his job. So if you get a case like that just before entering the room, then you need to think the first diagnosis, the ankylosing spondylitis. Yes, my dear doctor, if the case is something like that, the main concern is the unable to perform his own job and also difficulties in mobilizing. So you need to focus onto the full ankylosing spondylitis, full assessment that you need to do. Means that you need to examine and you need to talk the head to toe, whatever the problems he has. Means the ankylosing spondylitis, all the complications that you need to evaluate, all them together. So here's, my dear doctor, as because we already know that ankylosing spondylitis is a seronegative spondyloarthritis. And this seronegative spondyloarthritis is having all the A's bundle pack that you need to remember, all the A's that you need to know. So if you start from the eyes, that there will be the A for anterior uveitis or iritis. That is nothing but the red eyes or the painful red eyes. And if you get down to the lungs, there is an apical zone lung fibrosis. So once again, A for apical zone lung fibrosis. If you get down to the heart, then once again the rule of A for AV block, that can be first degree, second degree, third degree AV block. And as I said, that the bradycardia is a feature, or maybe the pacemaker scar and the pacemaker box will be there. And the heart complication, once again, the A for aortic regurgitation. So you'll get the murmur for the early diastolic murmur in the left heart interstitial space. And also you'll get the pulse, the high volume collapsing pulse. And next to the heart, another heart is the A for amyloidosis. Once again, I say the amyloidosis equal to RCM plus NOS plus HS. What does it mean? The amyloidosis is equal to RCM, restrictive cardiomyopathy. So in that case, they will get the apex bit will be the heaving in nature. And then the NOS is the nephrotic syndrome, urine dipstick will give the idea. With the massive proteinuria and the nail, you'll get the leukocythemia, and the leg edema, you'll get the leg edema. So these are the features that you can expect. And next is an abdomen examination, the hepatomegaly that you'll get, might have for the amyloidosis. So yes, once again, that you come back from the anterior uveitis, apical zone fibrosis, AV nodal block, aortic regurgitation, and then amyloidosis that leads to the restrictive cardiomyopathy in the heart, and A for rule getting down to the abdomen, then you get the hepatosplenomegaly. Means the amyloidosis is equal to hepatosplenomegaly and the NOS, nephrotic syndrome, and the restrictive cardiomyopathy. And you get down to the thighs and the legs. These are important matters that you need to know. Means the joints is really important. Means in ankylosing spondylitis, the axial joints is involved. Means the spine, with the spondylitis, the spine joints is involved. With the cervical spine, lumbar spine, the whole spine will be involved. Axial joints, along with the SI joints, the sacroiliac joints. Other than the axial joints, the appendicular joints are also involved. We call it the asymmetrical oligoarthritis. So there will be the asymmetrical oligoarthritis. We call the mono is a single, and the oligo is a 2 to 5 joints, and poly is a more than 5, is a 6 joints. So there may be the small joints in the hands, or maybe the right ankle, or maybe the left wrist joint, or maybe the left knee joint. So in an asymmetrical varieties, oligoarthritis may be present. So arthritis, A for arthritis, lacks the A for arthritis rule. So here's the axial joints arthritis and also asymmetrical oligoarthritis. And getting down to the legs, these are enthesitis. A for enthesitis, yes, you can say. So A for enthesitis means that the Achilles tendinitis and also plantar fasciitis, there is lots of A's. And last is a coda A equina A syndrome. It's a coda equina syndrome. So head to toe, these are the features that you can expect in a patient with the ankylosing spondylitis. But this gentleman having a concern with the mobility problems. So we need to show all the features of ankylosing spondylitis, and I will show all the possible features that he has of the ankylosing spondylitis, rather than going to the systematic ways of station 5 approach. But getting the findings in your hands, that you can formulate the things in the real exams and making the diagnosis and saying the examiner and also your patients as well, so that you can get the full marks in station 5, 28 out of 28 marks, my dear. So what you need to do, you need to look at him to see at the general survey and to see any of the walking aids that he has, and also the prism glass. That is really important. And immediately after that, you have seen the surroundings, bedside surroundings, then you need to look at the eyes, and you can ask him, is there any painful red eye? So he doesn't have the red eye, no painful red eye. And also to just open his body.
First time in the world. Most effective course. MRCP UK PACES, a complete online course. 5 complete stations, 8 encounters, 32 modules. More than 100 history cases, communications and skills cases. More than 200 clinical cases and clinical approaches. More than 400 presentations. 500 plus hours video lectures. 1000 plus notes, SS boxes, SS tips and tricks, questions and explanations. One of the best PACES mentor, world-famous experienced, skillful and expert MRCP UK teacher. Learn with Dr. Sumanta Kimar Saha, Chairman and Course Coordinator of SsAcademy.
The best and the best and the best course ever you will experience in your whole life, my friend. it will be helpful for us. Sir, could you just open the body so that we can get the findings in our hands? So yes, then we can see the psoriatic rashes, because the seronegative spondyloarthritis also associated with some extra-articular manifestations. So yes, the psoriasis skin rash may be associated or maybe present in that case. So you can do can you do like this for me, sir? And you need to look at these areas and these areas for the psoriatic skin rashes. Thank you, sir. Thank you very much. And you can go back to him just to see the back of the ear and back of the ear and below the hairline, scalp. So he doesn't have any of the psoriatic skin rashes. So what we need to do, we need to look at him, that his spine and everything at general survey. And I'd like to see him that little bit walking, just forth and back. I'd like to see the spine, the full spine, and the movement of the neck and the lumbar spine all together. So I'd like to tell him, sir, will you please just stand up for me and just walk for me? So I'd like to show his spine. So you can see the cervical spine is hyperextension and also the loss of normal lumbar lordosis. So you can see a question mark posture that the gentleman had. So yes, there's nothing but the consistent ankylosing spondylitis that he has. So now let's see, he will walk for me, just walk. So now we can look at him. So he's walking, so we can see the posture at him. So we can see the back. Now we can see the posture. Yes. So turn back, sir, now. Turn back for me. Turn back. Yes. Yes, sir. So turn back. So we can see the spine as well as the movement all together. Turn back, sir, for me. Once again, come. Walk for me. Yes. Now turn back once again. Turn back. Yes. Bas. Turn back, sir, for me. Turn back. Wait, sir. Turn back. So yes, sir. What we can observe that he has a question mark posture and the ported belly as well altogether. So yes. So this is nothing but the locomotor system examination, and that starts with the look, feel and move. Then you already observe him and the question mark posture with the restricted movements and hyperextension of the cervical spine and also loss of lumbar lordosis. So this is look that we have found that he has got the ankylosing spondylitis with a protuberant abdomen that he has. And now the feel. Feel is really important to see any of the tenderness of the spine that he has or not. So we need to turn him. Sir, can you just turn back? Yes. Turn. Like this, yes. Now I'd like to feel of your spine. If you have any of the pain, just let me know, sir. Just feel the spine. Is there any pain, sir? Pain? All right. Which part? Here is the pain. So he's feeling the pain. Yes, he has got the pain. So he has a spinal pain. So he has some of the tenderness. So I need to feel the spine. So this is the tenderness that I need to look for. So this is the look, feel. And now that we'll go for the movement. So sir, what we are going to do now, we'll see the 6 important movements of the cervical spine. How much and to what extent they're restricted that we can observe here. So we need to tell him, just could you please just like this, do like this for me? So you can see I can move my chin and very close to my chest, but he is unable to do so. Do it more. So you see the great distance is here. So this is the flexion movement. Now the extension. So can you do like this for me? More. So see, I can do more, but he is unable to do so. So really restricted movement, the flexion and extension all together. Now, sir, can you just touch this ear with this shoulder? So like this. Like this. So see, I can do it more. but he cannot do so. Now right side, can you do like this for me? Right. Could you please start with your right ear with the shoulder? So really a great distance rather than me. You see, I can do it. Yes. Now the lateral rotation. So just turn round to the, move your head on the left side like this. I can turn down. You can see I can turn down, and you can see the difference is me with him. And now on the right side, you can see I can move, but he is not moving the way that I'm moving. So the 6 important movements, the cervical spine is really restricted. The flexion, extension, lateral rotation, and the left and right side movement, my dear. So the 6 important movements are really restricted in the cervical spine that you already observed. So yes, now we look for the spine movement of the lumbar spine movement. So we'll tell him, sir, could you do like this for me? Move. So I can do it more. You can see I can do it more and more. I can do it. So this is called the floor finger distance. So you can see the difference. The floor finger distance is more than that of me. You can see I can do it more. So there is a forward flexion and the backward movements. So I can do it more. So definitely he has got the restricted movement. Now the lateral bending. With the lateral bending, so I can do it more. You can see I can do it more. Now right inside, right.
First time in the world. Most effective course. MRCP UK PACES, a complete online course. 5 complete stations, 8 encounters, 32 modules. More than 100 history cases, communications and skills cases. More than 200 clinical cases and clinical approaches. More than 400 presentations. 500 plus hours video lectures. 1000 plus notes, SS boxes, SS tips and tricks, questions and explanations. One of the best PACES mentor, world-famous experienced, skillful and expert MRCP UK teacher. Learn with Dr. Sumanta Kumar Saha, Chairman and Course Coordinator of SsAcademy.
The best and the best and the best course ever you will experience in your whole life, my friend. I can do it more. Yes. So now with the lateral rotation, that we can see that I can do it. With me that you can compare, and now you see that I can do it more. So yes. So these are the 6 important movements that we have done, that he has got the restricted movement in the lumbar spine as well. Now we'll do the modified Schober's test. That's very important to see the restricted lumbar spine movement as well. So these are modified Schober's test. I'd like to make a mark point here. So there's a dimple of Venus, and then you need to put your hands and then you just make a good mark here. So you need to give the 10 centimeter above a marking and the 5 centimeter below here. I'm just putting mark over the clothes, but you shouldn't do that. So now we need to tell him, just could you please, without bending your knee, just touch your feet. Just bend, just a minute. Yes, bend now, bend more. So this is increasing only the 16, 17 maximum. So yes, thank you very much. So in a normal person, that is 15 centimeter in total. In a normal person with a bending that goes more than 20 centimeter, means more than 5 centimeter extension of the lumbar spine or interspinal space altogether. But here is only 1 centimeter increase. This is said that if it is less than 5 centimeter is increase, so this the Schober's test or modified Schober's test is positive. So his Schober's test is positive. So this is the finger floor movements. So if you can make it, you see, this is around 50 centimeter. So finger floor distance is 50 centimeter. So in a normal person, the finger floor distance is less than 10 centimeter. In his case, the 50 centimeter is so increased. So the 10 centimeter. So now we are seeing the chest expansion that you need to measure. You see this is around 99 centimeter. So you can tell him, take a deep breath in. More. So this is no or less movement. It is less than 2.5 centimeter is positive. So yes, his movement on the chest is reduced. So sir, can you just make it more close to the wall? So this is we call the occiput wall distance, usually 0. If I can touch, just can you go there? That's right, sir. So we can compare with him. So you see the long distances. So that should be 0. You see, if I touch, I can touch. Is it locating here that I can touch? I can touch, yes. So I can touch, but he cannot touch. You see, this is 0. He has got the long distances. So this is occiput wall distance 0. Chest expansion is a 2.5 centimeter. More than 2.5 centimeter chest expansion should be. And the shoulder stretch more than 20 centimeter. And the finger floor distance more than 10 centimeter. So 0, 2.5, 15, 20 and 10 centimeter that you need to remember. So yes, my dear doctor, this is the station 5. So whenever the scenario says that he has got the increasing difficulty in mobilizing and performing his job, that you need to do all the maneuvers and showing all the features altogether. So my dear, listen very carefully. Then you need to know the 0, 2.5, 5 and 10. What I said, the 0, 2.5, 5 and 10. What does this 0 mean? 0 means O for 0 is O, so the occiput. So this occiput wall distance, that should be 0. It is increased. So definitely the number 1 findings that you found. And it's the 2.5 is the chest expansion. So normally more than 2.5. If it is less than 2.5, yes, this is also positive test. And then 5 means the Schober's test. Means the 15 centimeter normal, and more than 5 centimeter added means the total 20 centimeter. More than 20 centimeter is normal, but less than, in his case, there's only 1 centimeter. So this positive Schober's test as well. So 5 centimeter, as I say. And last, the 10 is a floor. 10 is a floor. Yes, means the finger to floor distance less than 10 centimeter. In his case, the 50 centimeter. So yes, so you need to remember the 0, 2.5, 5 and 10. Then you need to show the examiners these are the things along with the cervical spine movement and the lumbar spine movement altogether, showing them that yes, the diagnosis is the ankylosing spondylitis. Yes, my dear doctor, listen very carefully. What you need to do, you need to explain him regarding the ankylosing spondylitis. And after that, what is the management plan that you need to do that? Sometimes in the station 5, the scenario will be something like that. The man is presented with the shortness of breath on exertion. So yes, my dear doctor, he entered in the room that you have seen, he has got the ankylosing spondylitis. Now the shortness of breath on exertion, the differential diagnosis that you need to think about. Number 1, the apical joint fibrosis. And secondly, the heart disease. The heart disease includes maybe the aortic regurgitation leading to the chronic heart failure, the number 1, or maybe the restrictive cardiomyopathy having heart failure, or maybe the third AV block leads to the heart failure. So yes, the heart disease, and the first one, what I said, the lung disease. So shortness of breath on exertion, what you need to do, you need to lie back in 45-degree angle, then you need to examine the pulse for the high volume collapsing pulse for the aortic regurgitation, and you need to put the stethoscope and also put the hands for the apical impulse for the thrusting displaced apex bit, and also put the stethoscope to get the early diastolic movement. Along with the findings, as I said, the first degree, second degree, third degree AV block, any of the scar mark for the pacemaker, or maybe the restricted cardiomyopathy for the AICD pacemaker scar. So these are the cardiovascular system examination. I also put the stethoscope directly onto the apical zones to get the crackles, to get the findings. So findings will be directing you to what is the likely diagnosis, and the patient may be concerned with the heart failure. So yes, my dear doctor, that whenever the station 5, the case is with the shortness of breath on exertion, that you need to think about the lungs disease first, cervical fibrosis, evidenced by the crackles, or the second differential diagnosis, the heart disease, the aortic regurgitation, maybe the severe aortic regurgitation leading to the left heart failure. These are two important diagnoses you need to think about, and you need to make the patient lie back onto the couch, and 45-degree angle, you need to put the stethoscope onto the apical zone and put the stethoscope onto the left lower sternal zone for getting the murmur of early diastolic murmur, and also the features of severity like the high volume collapsing pulse and the thrusting displaced apex pain, and also the short EDM, and also the lungs crackles, the basal crackles for the heart failure features. So yes, my dear doctor, I hope that the ankylosing spondylitis, with all the complications and with all the possible examinations that we learned from this case, and formulate all them together based on the scenario that we need to approach to this case, and asking him regarding the concerns, what is really his concern, then management them, and make a good planning further will be helpful, my dear. I hope that, my dear, you enjoyed. Thank you very much. Hello, sir. Good morning.
Good morning, sir.
Very good. So, sir, my name is Dr. Shah, one of the PACES candidate here today. I have been asked to examine your tummy. So, sir, what I'm going to do, I'd like to have a very good look first, feel, tapping, and listen to your tummy. So, do you have any pain right at this moment at your tummy? No. All right. So, during this examination, if you have any of the pain and discomfort, just let me know. I'll stop at that moment. Is it all right?
All right.
Thank you very much. Yes, my dear doctor, listen very carefully. You entered in the room, that you started the deep bundle packs altogether, and greetings, introduction, instruction, pain, position, and poser. So you have done everything, and position is lying flat for the abdomen examination, and poser means the exposure. You need to expose him. So you need to tell him, sir, would you please just open your shirt? Is that all right?
All right.
Yes. So, sir, could you please just sit forward for me? I'm helping you. So I understand that you have some of the problem, right? Mobility.
First time in the world. Most effective course. MRCP UK PACES, a complete online course. 5 complete stations, 8 encounters, 32 modules. More than 100 history cases, communications and skills cases. More than 200 clinical cases and clinical approaches. More than 400 presentations. 500 plus hours video lectures. 1000 plus notes, SS boxes, SS tips and tricks, questions and explanations. One of the best PACES mentor, world famous experienced skillful and expert MRCP UK teacher. Learn with Dr. Sumanta Kimar Saha, Chairman and Course Coordinator of SsAcademy.
The best and the best and the best course ever you will experience in your whole lifetime. Just sit forward for me. Yes. So I can help you to put off your shirt. Now put off your shirt. So yes. So yes, my dear doctor, just look at him whenever you're just putting off your dress and shirt, and we can observe him that the hyperextension of the cervical spine, and you can see the loss of normal lumbar lordosis and making a question mark posture. It's a spot diagnosis for the ankylosing spondylitis. And if you just tell him, can you just turn your head on the left side?
Left side, okay.
And then now right side now. Yes. So you can see some of the restricted movement of his neck. So yes, my dear doctor, immediately after entering the room, the station 1 abdomen. And whenever you felt that this man would have the difficulty in moving his neck joint, the spine joints, and having typically the question mark posture, having the hyperextension of the cervical spine, and also the loss of normal lordosis of the lumbar spine, along with the protuberant abdomen, is a typical and the spot diagnosis for the ankylosing spondylitis. So yes, my dear doctor, this is knowing the facts, the ankylosing spondylitis. So whenever you are focusing in the station 1 abdomen, then you need to examine the abdomen. So you need to anticipate fast what things that you are expecting in a patient with ankylosing spondylitis. So in an ankylosing spondylitis, the rule of A in abdomen, there's a amyloidosis that you're expecting. And the amyloidosis equal to the box that you need to know, my dear, there is a RCM plus NOS plus HS. So what I said, the RCM means the respiratory cardiomyopathy, nephrotic syndrome, and the hepatosplenomegaly. So I'm saying the amyloidosis, the rule of M also. M for yes, once again, the myopathy means the cardiomyopathy, restricted cardiomyopathy, and NOS means the nephrotic syndrome, means the massive proteinuria, and third is the megaly, is the hepatosplenomegaly, and fourth M is once again the macroglossia. So in an abdomen station means the GIT that we are expecting in a patient with ankylosing spondylitis, the findings of the amyloidosis is hepatosplenomegaly. So we need to be very focused onto the hepatosplenomegaly along with the features of nephrotic syndrome. So the nephrotic syndrome, the features will have definitely the leukonychia in your hands that you are expecting. And the second important point, there's an edema. So these are the two important findings. Along with the urine dipstick will have the massive proteinuria. So the nephrotic syndrome done. Along with the hepatosplenomegaly that you need to examine the patient to get the liver and to get the spleen. If you found them, putting them together, hepatosplenomegaly, along with that, the nephrotic syndrome, so you can make the diagnosis. The amyloidosis is the complications of ankylosing spondylitis. So you need to examine, focusing and keeping them in your mind. Then you need to start your examinations, my dear. And you need to be very focused with the findings that I said in the hands that you're expecting for the leukonychia, and the leg for the leg edema, and the anal sarca, and also aside is also the fluid overload, whatever the forms, but the leg edema that we're expecting, sacral edema as well. And along with that, the urine dipstick at the bedside for the massive proteinuria. And also the liver and the spleen, then palpations that you need to do, my dear. And along with that, you should palpate the kidneys as well. And of course that you will do all the steps of abdomen examination, but I will be very focused for the ankylosing spondylitis, what the findings that you are expecting, so that we can get the idea in station 1 abdomen, then what things that you need to focus, my dear, and you need to get the findings in your hands. So let's start by showing whether he has got the leukonychia or not. So in the hands that we are looking for the leukonychia, so he doesn't have the leukonychia. So he doesn't have leukonychia. And also no clubbing, and also turn his hands to look for the pulmonary erythema and the Dupuytren's contracture. So he doesn't have any other features of chronic liver disease. Then you need to do all the procedures altogether. But yes, as because we are focusing for the leukonychia, especially for the nephrotic syndrome that we are looking for as due to the hypoalbuminemia, but we are not getting these findings, means the leukonychia is absent. So in an inspection that we are looking for the abdomen distended, is just a fatty abdomen, or maybe the hepatosplenomegaly is there. So it's an inspection findings. But what I'm looking for, we are looking for the leukonychia due to the hypoalbuminemia, and I'm just showing in a non-systematic ways so that you can keep them in your mind, so that you can examine all them together in a patient with ankylosing spondylitis. So yes, we are saying here, do you have any pain at your legs? You need to tell him. So he doesn't have the leg edema. So it does mean that he doesn't have the features of nephrotic syndrome. And then you need to do, and you need to keep in your mind that the urine dipstick for the massive proteinuria, then you need to look for. So it's because we found no leukonychia, no leg edema, so the no nephrotic syndrome. I'm showing in a non-systematic ways, just to keep the features in your mind so that you can focus during examination of the abdomen, full abdomen examinations, my dear. So now I'm focusing on to the abdomen, just to give you the idea, the gentleman has got the hepatosplenomegaly. So yes, you need to focus. Once again, you need to put your hands like this, and you need to tell him, just take a deep breath in and out. So yes, once again, once again, once again. So he has got a good hepatomegaly. So you need to confirm it by doing the Parkas. Tympanic. Done. Done. So all them done. So this is the liver dullness, and you need to focus on the upper border of the liver dullness. Tap on the chest. So this is the dullness. So is the second, third, and this is fourth. So you can put the liver is enlarged. So you can feel the liver span is really enlarged as hepatomegaly. But the border is not irregular, and the border is not, and also the liver is non-tender. So I found this 3-finger base hepatomegaly, which is non-tender, firm in consistency. The border is not irregular. It does mean that the border is not irregular, that you are excluding the hepatocellular carcinoma. And non-tender means you are excluding the congestive cardiac failure. So these two important things that you need to always say: the border is not irregular, and the non-tender, firm in consistency, no bruise overlying the mass. So you need to take the stethoscope in your hands, that with the bill of the stethoscope. Yes. You need to put the stethoscope to see the bruise. So no bruise overlying this mass. So it's just an hepatomegaly, 3-finger base, non-tender, firm in consistency, and no bruise overlying this mass. So this is hepatomegaly that you found. So yes, my dear, you got a hepatomegaly, and now that you need to focus onto the spleen, then you need to put your hands from here, take a deep breath in and out. So yes, I can feel the anterior border of the spleen as well. Yes. So yes, the border of the spleen that I can feel. So this is the splenomegaly that you found. So you need to do the tap on the tympanic. So this is done, this is done. So this is the splenomegaly once again that you found. So once again, that whenever the spleen you found, you Parkas, and you need to put the stethoscope to see the bruise as well. So no bruise overlying this spleen. So immediately after that, you need to look onto the anterior chest, especially the left infraclavicular space, to look for any scar mark or any box underlying them for the EICD pacemaker, because I said it, the amyloidosis is strongly complicated by, or amyloidosis features is RCM, respiratory cardiomyopathy, and this respiratory cardiomyopathy is also treated with the EICD pacemaker sometimes. So you need to look for, there is no EICD pacemaker scar. So I can say that he may have or he may not have the respiratory cardiomyopathy. You need to look for by doing the echocardiography test. So my dear, what you need to do, you need to take the shot and give him back once again. And just cover him up like this and tell him, sorry, thank you very much. Means you need to do all the steps, whatever you need, my dear. But the main findings that I need to discuss, so that you can get the things, keep in your mind, focusing on them, get the findings in your hands, put together, make the diagnosis, and present your case, my dear, the way that I'm saying. So yes, my dear, listen very carefully. Immediately after finishing, you need to wash your hands. You shouldn't forget it. And now listen very carefully. If you get, my dear, a case for the ankylosing spondylitis and abdomen examination, think about the diagnosis. The first diagnosis, the amyloidosis. As I said, the amyloidosis equal to the RCM plus NOS plus hepatosplenomegaly. And the macroglossia. Yes, he doesn't have the macroglossia. I'll not show them. So my dear, listen very carefully, as because I have said in a different ways also. The M for myopathy, amyloidosis, M rule. The myopathy means the respiratory cardiomyopathy. M for massive proteinuria means the nephrotic syndrome. And M for megaly means the hepatosplenomegaly. So we are focusing here the findings of the hepatosplenomegaly without the features of nephrotic syndrome, but still that in your hands that you can do the urine dipstick for the massive proteinuria. So the presentation should be something like that. You need to tell to your examiner, sir, my clinical diagnosis of this man is amyloidosis as evidenced by hepatosplenomegaly, 3-finger beds on the right costal margin, liver is enlarged and palpable, which is firm in consistency, non-tender, non-pulsatile, and not irregular border, and no bruise overlying the mass. Along with the spleen is 4-finger base on the left costal margin, which is firm in consistency, with the knot in the anterior border, which moves directing towards the right iliac fossa, and Darlon percussion, and no bruise overlying the spleen. So putting all them together, I found the hepatosplenomegaly, but I have not found the features of macroglossia. I have not found the features of nephrotic syndrome as evidenced by the leukonychia, absence of leukonychia, and absence of leg edema. And also I have found, and I would like to do the urine dipstick to exclude, or maybe to include, the massive proteinuria at the bedside of the urine dipstick, the massive proteinuria. So putting all them together, I think this gentleman has got the amyloidosis, which is the secondary complications or the complications from the ankylosing spondylitis. I have seen whenever he has got the reduced mobility of his spine, so, and also having a question mark posture as evidenced by the hyperextension of the cervical joints and also the loss of normal lumbar lordosis. Putting them together, he has got the ankylosing spondylitis. And I have not seen any of the scar mark in the left upper chest, in the left infraclavicular space. That does mean that he has not having the AICD pacemaker scar. Maybe he has the restricted cardiomyopathy, but I need to do the test, means the echocardiography, or maybe the cardiac MRI, we call it the CMR, to confirm the diagnosis for the restricted cardiomyopathy. So my clinical diagnosis of this gentleman is hepatosplenomegaly, which is consistent with the amyloidosis, which is the complications for the ankylosing spondylitis without the evidence of nephrotic syndrome. I hope that, my dear, this interesting case, you enjoyed it, and the learning that you learned, my dear, that will be really helpful for in station 1, abdomen, if you get the case, something like that. Thank you very much. So yes, my dear doctor, listen very carefully. Station 1, respiratory system. You entered in the room that you have seen whenever you put off the dress, and you have seen this gentleman has got the question mark posture, and which is evidenced by, that is the hyperextension of the cervical spine and loss of lumbar lordosis with the restricted movement of the neck and all the whole spine, that made you diagnose ankylosing spondylitis. So now you need to know about, if the patient is given to the respiratory station, ankylosing spondylitis, what is the diagnosis? The first diagnosis is a pulmonary fibrosis. And this is predominantly the apical zone. And apical zone is the front of the chest that you need to focus onto the upper chest and the upper apical zones in the front of the chest. And for the basal part, then you need to examine the back of the chest. So the front of the chest, the apical zone, then you need to focus to get the inspiratory crackles. So this is the most important thing that you need to know, my dear. So yes, my dear doctor, just look at him whenever you're just putting off your dress and shirt, and you can observe him that the hyperextension of the cervical spine, and you can see the loss of normal lumbar lordosis and making a question mark posture. It's a spot diagnosis for the ankylosing spondylitis. And if you just tell him, can you just turn your head on the left side, now right hand side, right side now? Yes. So you can see some of the restricted movement. So yes, my dear doctor, that I'm very focusing onto the respiratory system examination. You will do everything, my dear. Starting examination from the foot end, then the 45-degree angle and exposure, everything you do, my dear, all the G bundle packs, everything you do. But the focusing onto that is because you found that he has got the ankylosing spondylitis, so that you focus onto the apical zone fibrosis. Whenever the fibrosis is concerned, then you need to look at the hands to exclude the clubbing, my dear. This is very much important. So at least that we need to see the hands for the clubbing. Can you show me your hand? So in the hands that we are looking for the leukonychia, so he doesn't have the leukonychia. So he doesn't have leukonychia. And also no clubbing, and also turn his hands to look for the palmar erythema, and the Dupuytren's contracture. So he doesn't have any other features of chronic liver disease. That you need to do all the procedures altogether. But yes, because we are focusing for the leukonychia, especially for the nephrotic syndrome that we are looking for as due to the hypoalbuminemia, but we are not getting these findings, means that leukonychia is absent. So yes, I've seen that he has no clubbing. Yes. One of the most important talk in respiratory system examination, that is the respiratory system, starts with the CEP and BSVR, with the chest expansion, percussion note, and breath, and the CEP and BS for the breath sound, and the vocal resonance. So all the things that you do, but the added sound, the crackles, my dear, you need to focus. You need to show the apical zone having all the features are getting down. With the C for the chest section getting down on the apical zone, rather than the mid zone and the lower zone. You need to show them. So let's see. Just can you do like this for me? And you need to hold it here. Just put your hands and tell him.
First time in the world. Most effective course. MRCP UK PACES, a complete online course. 5 complete stations, 8 encounters, 32 modules. More than 100 history cases, communications and skills cases. More than 200 clinical cases and clinical approaches. More than 400 presentations. 500 plus hours video lectures. 1000 plus notes, SS boxes, SS tips and tricks, questions and explanations. One of the best PACES mentor, world-famous experienced, skillful and expert MRCP UK teacher. Learn with Dr. Sumanta Kimar Saha, Chairman and Course Coordinator of SsAcademy.
The best and the best and the best course ever you will experience in your whole lifetime. Turn your head on the left side, sir. You see that he's really unable to move, so the apical zone is really less movement. So you need to show that the apical zones having really restricted movement on the chest expansion is really reduced. So tell him, take a deep breath in and out for me, sir. Once again. So you see the chest movement is really reduced. And we say that the ankylosing spondylitis, usually a normal person with the chest expansion is more than 2.5 centimeter, but he has less than 2.5 centimeters. So the reduced chest expansion. Immediately after that, the C, then the P and the percussion note that you need to show him, the apical zones having the dull percussion note. So you need to tell him, sir, just turn your head on the left side. You need to put your hands there. And this is dull. You see the dull sound? Once again, dull sound. But here is a tympanic, 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 tympanic. Or resonant, you can say the resonant rather than the tympanic. Resonant sound. So C, percussion is the dull on the apical zone especially. And then the breath sound. And you need to take the stethoscope and put the stethoscope once again here. And stethoscope with the bell, So you need to put the stethoscope here and you tell him, take a deep breath in and out. Once again. So breath sound also reduced. Once again, sir. Once again. You need to turn around like this. Along with that, you need to listen now the added sound. Once again, I can listen the inspiratory crackles here. Once again, sir. Thank you very much. So I can listen the inspiratory crackles on the apical zones, the added sound. So CEP and BSB are with the chest function reduced, percussion are down, and the breath sound diminished or getting down, and the vocal resonance also getting down. I have not shown here. And you need to just put the stethoscope like the way the 99, and the added sound, the inspiratory crackles that we found. So we found the crackles, inspiratory crackles, predominantly apical zone, and without clubbing. So definitely the pulmonary fibrosis consistent or the complications for the ankylosing spondylitis. And you need to also put the stethoscope to the back and going the examination and showing them there is no or less crackles in the basal zones as well. So yes, my dear doctor, that immediately after finishing your examinations, whenever you felt that you finished your examination, you need to do all the steps that whatever is instructed in other video clips for the respiratory system examination. You need to do that, and you need to wash your hands, definitely finishing your examination, and of course you need to tell them how you are finishing the examinations here. Yes, my dear doctor, what will be the presentation? That's really important. You need to present your case the way that I'm saying, my dear. You need to tell that my clinical diagnosis of this man is pulmonary fibrosis, as evidenced by the chest expansion is reduced predominantly over the apical zones, and as well as the percussion rate is dull. Along with that, the breath sound is diminished and the vocal resonance is diminished, and also there is an inspirative crackles that I found over the both apical zones, predominantly over the both apical zones of the both lungs, without having the clubbing, nicotinic staining and other findings altogether. So this is consistent with the pulmonary fibrosis. And this pulmonary fibrosis is complicated by the respiratory failure. If the features of the oxygen means the hypoxia, means as evidenced by the cyanosis, but I found there is no cyanosis right at this moment. And also this is not complicated by right heart failure, means the core pulmonary, as evidenced by the leg edema, absence of leg edema. And this gentleman is not on steroid, as the absence of any steroid stigmata at the peripheral side. And this pulmonary fibrosis, the underlying etiology is ankylosing spondylitis. As I have seen, this gentleman has got the question mark posture, as evidenced by the hyperextension of the cervical spine and loss of normal lumbar lordosis with a protuberant abdomen. So it's consistent with ankylosing spondylitis. So underlying etiology of pulmonary fibrosis is apical zone pulmonary fibrosis is ankylosing spondylitis. I would like to confirm my diagnosis by doing the HRCT test along with the pulmonary function test. And also, if needed, that sometimes the MRI is really more sensitive to detect the apical zone fibrosis. I hope that, my dear, the findings and the expectations and the anticipations of ankylosing spondylitis, the apical zone fibrosis that you think and you put and you focus over there, you'll get the diagnosis in your hands, my dear. I hope that these important tips and tricks will be really helpful in your real exams, my dear. I hope that you enjoy. Thank you very much. So this is Station 3 Cardiology. Station 3 Cardiology, my dear. You entered in the room that you have seen. Whenever you put off the dress, put off the shirt, then you felt this gentleman has got the restricted spine movement along with the question mark posture, and that is a hyperextension of the cervical spine and the loss of normal lumbar lordosis is consistent with the ankylosing spondylitis. Whenever you have seen the ankylosing spondylitis, my dear, you need to know what the findings or what the complications from the ankylosing spondylitis that can be happening in cardiovascular system, that you are given this patient in a cardiovascular system Station 3. So you need to know for the ankylosing spondylitis, the rule of A, once again, A for the AV nodal block. It can be primary, it can be secondary. So in that case, in your real examination, you can get or you can expect a small scar, a small box with a pacemaker box on the pacemaker for the third degree AV block. And secondly, the aortic regurgitation. This is very much important. The findings that we are expecting in a pulse that we will get the high volume collapsing pulse. And then in the blood pressure, from the starting of the pulse and then the blood pressure, we are expecting to get the wide pulse pressure. And this is the severe nature of the severe aortic regurgitation. Immediately after that, in apex beat that we are finding, we are expecting that the displaced, thrusting R for regurgitation, thrusting and displaced apex beat. And immediately after that, the murmur is really important. There is an early diastolic murmur. There is a short early diastolic murmur. The short early diastolic murmur is a feature of severe aortic regurgitation. So yes, my dear doctor, this is very much important to get the findings all them together, making the diagnosis aortic regurgitation. Means what I'm saying, in ankylosing spondylitis cardiovascular system, that first of all, that you need to think about the first degree, second degree, third degree AV block. Third degree AV block is evidenced by the scar mark below a small box for the pacemaker that we are expecting, number one. And secondly, for the aortic regurgitation findings. And thirdly, restrictive cardiomyopathy. Restrictive cardiomyopathy will have the apex beat will be the heaving in nature, or the apex beat will be thrusting in nature in case of aortic regurgitation or severe aortic regurgitations. So these are the findings that we can expect. And for restrictive cardiomyopathy, sometimes the AICD pacemaker could be given. So in that case, a small scar below a bigger size box for the AICD pacemaker. The AICD pacemaker is a bigger pacemaker box, and the normal pacemaker for the third degree block is a smaller size pacemaker. So these are the differences. So yes, my dear doctor, keeping in your mind that we are expecting for the pacemaker for third degree block, pacemaker box or the scar for the RCM, and for the ER findings altogether. So what you need to do, we need to examine, and I would like to show you here, rather than the systemic ways of examination, I would like to show what findings that we are expecting here. So we need to start from the examination from the hands, my dear. You need to wash your hands, of course. And of course, you need to start from the hands. You need to tell him, so I would like to examine your pulse. And you need to feel the pulse. And the steps that you need to feel the rate fast. Immediately after that, the irregular, that the fibrillation that you are expecting for the mitral valve disease. And if you're not getting the fibrillation with irregular pulse, then the low volume. Not low volume, then high volume. Means you are expecting the high volume pulse. So yes, I can feel the high volume pulse. So anybody feel the high volume pulse, you need to hold it here, and you need to hold it here, and you need to tell him, do you have any pain at the shoulders? Huh? No. So you need to see the collapsing pulse as well. So yes, I found he has got the high volume collapsing pulse. Immediately after that, the most important thing is that you need to focus onto the apex beat and the auscultation. And you will get all the findings of the aortic regurgitation. But the most important thing is the auscultation that you need to do with a good maneuver. You need to make the patient sitting forward or leaning forward with the diaphragm of the stethoscope. You need to hold over the carotids, and then you need to examine the aortic regurgitation murmur. And now you can see that there is no scar mark here, no scar mark for the small scar mark, is a small pacemaker box for the third degree block, and no bigger box for the RCM. So this is not there. And then we can feel the apex beat. And these apex beat are here. Yes, I can feel the apex beat here. A bit of thrusting apex beat. And immediately after that, the auscultation. So you need to auscultate him. So you need to put the stethoscope with leaning forwards. Sir, would you please just sit forward for me? No. Is it okay?
No.
No, all right. So he cannot actually be able to sitting forward. So what you need to do, you need to put the stethoscope over the left third intercostal space.
First time in the world. Most effective course. MRCP UK PACES, a complete online course. 5 complete stations, 8 encounters, 32 modules. more than 100 history cases, communications and skills cases, more than 200 clinical cases and clinical approaches, more than 400 presentations, 500 plus hours video lectures, 1000 plus notes, SS boxes, SS tips and tricks, questions and explanations. One of the best PACES mentor, world-famous experienced skillful and expert MRCP UK teacher. Learn with Dr. Sumanta Kimar Saha, Chairman and Course Coordinator of SsAcademy.
The best and the best and the best course ever you will experience in your whole life, my friend. I need to tell him turn your head on the left side for me. I need to put the left hand over the carotids here. I need to tell him take a deep breath in and out and hold it there. So a closer view that you can see that you need to put the stethoscope here, the left third intercostal is the second, is the third, left third, and you need to put your hands here, and you need to tell him turn your head on the left side for me, and now you need to tell him take a deep breath in, out, and hold it there. And I can listen. I can listen the sound. The faster sound, immediately after the second sound, there is no single component. The sound is there. So I found a very good murmur. That is the early diastolic murmur that I found, and that is best third in the left third intercostal space with the diaphragm of the stethoscope, with the breath holding after expiration, with the leaning forwards. This is most important, as because my gentleman cannot able to just sit forward, so I need to do, and you need to do examine like the way that I have done. So this is the one that we found in early diastolic murmur, along with the high volume pulse, with the apex beat thrusting and also displaced. So diagnosis is severe aortic regurgitation without having evidences of AV block, without having evidences of restrictive cardiomyopathy. So you need to present your case the way that I'm saying, you need to do all the steps, whatever you need for the cardiovascular system examinations, my dear. You need to present your case like the way that I'm saying. My clinical diagnosis of this man, of this gentleman, is severe aortic regurgitation, as evidenced by the high volume collapsing pulse and thrusting displaced apex beat, along with the short early diastolic murmur. And this severe aortic regurgitation is not complicated by left heart failure, as evidenced by absence of lungs crackles, and also not complicated by the right heart failure, as evidenced by the absence of leg edema. And also this gentleman severe aortic regurgitations is not complicated by infective endocarditis, as evidenced by the absence of all the peripheral stigma of infective endocarditis. I'd like to, and putting all them together, my clinical diagnosis of this gentleman is severe aortic regurgitation. So I'd like to show his spine. So you can see the cervical spine is a hyperextension, and also the loss of normal lumbar lordosis. So you can see a question mark posture that the gentleman had. So yes, there's nothing but the consistent ankylosing spondylitis that he has. So now let's see, he will walk for me. Just walk. And also I have seen this gentleman also having the restricted movement of the spine and also having the question mark posture, as evidenced by the hyperextension of the cervical spine and loss of normal lumbar lordosis, which is consistent with the ankylosing spondylitis. So with the ankylosing spondylitis is complicated by the severe aortic regurgitation. So this severe aortic regurgitation, the underlying etiology is ankylosing spondylitis. So putting all them together, my clinical diagnosis of this gentleman is severe aortic regurgitation due to ankylosing spondylitis without evidence of heart failure and without evidence of infective endocarditis. I'd like to confirm my diagnosis by requesting a color Doppler echocardiography that gives an idea of aortic regurgitation and the severity of this aortic regurgitation. And the examiners will ask you the other questions, the similar ways that you need to tell them that the cardiovascular complications of ankylosing spondylitis are. Of course, the first one, as I say, the first degree, second degree, third degree AV block, that can be evident by, yes, the bradycardia in the pulse, and also the pacemaker. And the second complication, the aortic regurgitation, that the findings that we found here. And the third is the restrictive cardiomyopathy as the complications for the amyloidosis. And restrictive cardiomyopathy, yes, once again, the apex beat will be the healing in nature. And all them that you need to confirm the diagnosis by doing the different tests, including the echocardiography, X-ray, ECG, and maybe sometimes we need the cardiac MRI for the cardiomyopathies. So yes, my dear, this is very much important tips and tricks. You enter in the room that you have seen the ankylosing spondylitis, you think of that these can be the possibilities, so you need to focus so that you can make the diagnosis on your hands. Otherwise, it's really impossible, my dear. I hope that, my dear, getting the clues and think of what will be the diagnosis, what will be the focusing points that you can, and you get the findings in your hands, putting them together, make the diagnosis, saying the examiner presently the way that I presented. That is the best tips and tricks, my dear. You'll do the best, and I hope that you enjoy. Thank you very much.